Um, Hello, welcome everybody. I'm Larry Patterson, Crossville, Tennessee. I'm going to be talking for a few moments about bringing standardization and accurate refraction to your practice. Let me make sure I'm doing this right. Here we go. Just a little bit about our background, because when people talk about these situations, you need to know a little bit about what they're talking about, because every situation is unique. I Centers of Tennessee is my practice. We have our main office in Crossville, Tennessee, but we also have 4 satellite offices that are wholly owned by us. We have a total of 3 ophthalmologists and 5 optometrists. It's general practice, although we've just recently brought retina on board, mostly cataract and refractive surgery as far as the surgery goes. And I see 80 patients a day by myself, so that gives you an idea of what we're doing. And most of what I'm going to be talking to you about will be how this works as far as my practice itself goes. Our main office staff, we have 4 front office people, 4 opticians, 3 techs, 2 scribes, and a surgery coordinator. Now there's actually more staff than that, but these are the staff that I guess subserve, take care of me. When there are other doctors working, there are other scribes and technicians working for them. We have the Marco Epic machine and have had it for a long time. This is a picture from way back when. We actually evaluated a couple of machines going back to '97, and in 1999 we purchased our first Epic, and this is a picture of that back then. I want to tell you a little bit about our staff preparation, how this actually all worked out for us. We really recommend, if you're buying this sort of system, that your staff really buy into the program, and you do that by talking it up, telling them how much better this is going to be for them. Now, most staff with most things are a little bit wary, they're a little bit concerned, worried, how much work is this going to be? I can tell you our staff, there's almost nothing they would want to give up. They don't like want to give up any of the technology we have in the office, but they would really be upset if they learned they were going to lose their Epics, because they love this. We sent our technicians to Florida for training. The way we did it is we sent 2, and we sent our most experienced refractionist and someone who's actually quite new to the practice, so that we had two takes on that. As things upgraded, we went from the 2100 to the 5100. It has a lot of new things: improved EMR integration, an intelligent cross-cylinder, touch screen, table raises and lowers a lot easier, and it's a little bit smaller footprint. This touch screen, we actually had it for some time before I realized what it did, but you can flip this so that you can see it, but you can also flip it over and the patient can see the small screen as well for certain specialized testing. The 4-opters are slimmer, they don't get as dirty easily, anti-smear technology. And with the addition of the newest Epics and the 3D waves, every person who comes to our office is going to be guaranteed they're going to get the very best refraction possible, and it's going to be consistent throughout the whole office. I've got, in my main office, I have as many as 8 to 10 different people who can refract, and I don't have to worry as much about who did the refraction. I know if they'll all follow the system the same way, they'll get similar refractions. The office flow is designed around the Marco Epic, and I'm going to show you a little bit about, just some pictures of our office. Let's see, well, the mouse here is not showing up. Let me see. Hang on just a second. No, okay. Well, anyway, you just have to, I'll point it out up here. But this is our office. When you walk in the front door, there's about a 150-foot hallway, it goes all the way down the office, but this is the reception area. We try to avoid the term waiting room, try to call it something besides that. In fact, we hope our patients aren't waiting there that long at all. Most of the time, you kind of want your waiting room to be empty, because there's, we want the patients to check in and get going and try to stay on time. This is an overview, sort of a blueprint of the whole first floor, and this is where you were standing looking down this long hall, and these blue areas are the patient clinical areas, and this is one of our Epic machines. We have a mirror image here. These are pods of workup rooms. We have a little window here where you can actually see the Epic machine, and that's where the patients are first come into. So there again is the room, looking at it from the hallway. They walk in here where the Epic machine, and again, this is an older version. I haven't really updated my pictures recently. This is some windows, so people walking by can actually look in. They're tinted, but you can see what's going on. What we're doing here, this part of the exam is not private. There's nothing real personal going on. So all the people walking by can see the technology, which is really neat. Let me back up. In that room, we take a vision history, and I'll explain more about that later, lensometry, keratometry, and the refraction. And then we get them out of that room. And our goal is to have them in and out of that room in about 10 minutes. From that point, the patient goes into the history room. And in that room, they take the medical history, they do check motility, pupils, pressure, and dilate them. And that's all done in a very, very inexpensive room. Some of those rooms have slit lamps, some of them don't. From that point, they go from, and this is all laid out this way, they go from those rooms where they've been worked up, they've been dilated, they go directly into this blue area, which is optical. And for those practices that have optical, which I think in general ophthalmology practices is now well over 50%, it's just a short little walk over there across the hall, and they'll continue their dilating while they're picking out glasses, and hopefully they pick out a lot of stuff before they really dilate that much. Our scheduling is really, really important, and it's fairly unique. Most people's scheduling is based on doctor's time. In fact, I've seen schedules where they've got technician schedules, they've got doctor schedules, and people come in and they figure the tech will have them so long, the doctor will have them so long. We tell people, and we've been teaching this for years, that's a really bad idea. It's too complicated. Doctors' offices don't work that smoothly. We forget the doctor's time, because I know roughly how long a technician's going to need, but I have no idea as a doctor how long it's going to take me to see that patient. Someone may come in with a really bad problem. It may only take me 2 minutes to figure out what the problem is and realize we've got to send you to someone else. Someone else may come in with minor complaints of dry eyes, and I may be there for 15 or 20 minutes talking to them. But the technicians, we know roughly how long it's going to take. We evaluate the technician time and divide everything into short and long appointments. And to have short and long appointments, we have short and long techs. Here's a picture of our short and long techs. We don't actually do this based on height, but it really is based on the length of time it's going to take the technician to see them. Short appointments are scheduled every 10 minutes. And if you're on the short schedule and you're a technician, it means you're actually going to see 6 patients an hour. These are people who don't even go into that epic room. They're coming in for a follow-up, a pressure check. It's their first day after cataract surgery. One tech and one lane, and they're just going in and out, and that's no big deal. The long appointments are also scheduled every 10 minutes, but they're 20-minute slots. They're alternating. So there's a 8 o'clock long where the patient comes in at 8 o'clock, and she's got 20 minutes with them. The next patient comes in at 8:10, and the next long tech sees them for 20 minutes. So we're seeing about 6 patients an hour, but it's with 2 techs alternating. And they're using the same epic room and the same history room. They're just going in and out of them. To take care of bottlenecks, we actually have 2 history rooms so that in case you come out of an epic room and the history room's tied up, you can go to the other one. So this is kind of our workup paradigm shift. And we're going over these slides, and the girl who works with me, the Vicky, she said, we've got to get rid of that name paradigm shift. That's really old. That was really cool to say years ago, but we couldn't come up with another word. So we're still going with paradigm shift. The question was, does the medical history have to come first? In a traditional office, and the way we were taught in medical school, you take this long, exhaustive medical history, and after you've done that, then you start your examination. Well, our contention is your refraction is going to be the same regardless of the medical history. How you prescribe the spectacles themselves may be based on their vision history. So in a typical traditional eye doctor office where you're using techs, they do the medical history, then the visual history, then the vision, refraction, pupils, pressure, dilate, patient waits, they're watching the clock. After 45 minutes, they finally see the doctor. Everything's behind. They finally go to the optical dispensary. They pick out their glasses. It can be 2 hours or 3 hours even to get through that whole process. What we're doing now is the techs are going to do a quick vision history. And vision means, how's your vision? How are your glasses? What's going on with the seeing part of your life? And then they're going to do the medical history. They're then going to check their pupils. I forgot to say they do the refraction, which is what kind of this talk is about. Quick visual history, then the refraction, using the 3D wave, medical history, pupils, pressure, dilation. Now, as soon as they put the drops, they do the dilating drops the very, very last thing, because what they want them to do then is go straight to optical. So they've got several minutes to be looking at glasses before the dilation really kicks in. And they're picking out glasses. They usually got them picked up about the time they're dilated. Now they see me, and then they go home, and they're in and out in about an hour, and people really appreciate this because they've got better things to do than hang out at your office all day. So the first day we did the Epic in our office, and again, this is back 1999, we maintained our regular schedule. We did 6 long exams an hour, 2 techs. We didn't worry about the short schedule that day. Just did the longs. We took an hour lunch, took over talked about the glitches, problems, made a few adjustments, full schedule that afternoon. So we really didn't slow our schedule down to use the Epic. It really didn't slow us down at all. And even to this day, we keep doing basically the same thing. Now, some of the new changes with the Marco 3D Wave, this is going to add diagnostics and give people the very best possible prescription, because this is going to individually evaluate their optics system to a level we've never really been able to do before. I think the thing I like the most about the Epic system is being able to show patients their old prescription versus an intelligent wavefront adjusted prescription. And they're sitting there looking at that 4-opter. Instead of the old way we would say, here's vision with your new glasses, and we would take that away. They would put on their old glasses and look at the eye chart. Which did you like better? And that's really hard to do. With this new system, we can just click of a button, here's your old glasses, click of the button, here's your new glasses, do you see the difference? And most of the time they can. Sometimes they can't. Sometimes the new glasses, it's no different. So you tell them, you don't really have to buy new glasses if you don't want to, and they appreciate that. That's essentially the end of the talk, and I will leave it with that.